Assalamualaikum. Today we will discuss about the endometriosis. We will discuss NICE guideline and eshure guideline and some talk article. So we will start it. Basically, what is the endometriosis? Endometriosis, when there is an endometrial gland and the stoma, it is found outside the uterus. Then it is called the endometriosis. Okay, so there is the summary point. First of all, we discuss these point. Then we will discuss it separately. ओके, तो हम डायग्नोज कैसे करेंगे, क्या इसके डायग्नोस्टिक क्राइटेरिया हैं, पेशेंट हमारे पास कैसे प्रेजेंट करेंगी, या तो पेशेंट पेन के साथ प्रेजेंट करेगी या तो इनफर्टिलिटी के साथ प्रेजेंट करेगी। ठीक है, ये इसके दो मोस्ट कॉमन सिम्टम्स हैं, डिस्मेनोरिया एंड इनफर्टिलिटी। ओके, बाकी पेशेंट को डिस्पेरिनिया भी हो सकता है, बाउल और ब्लैडर सिम्टम्स भी हो सकते हैं, और एबनॉर्मल वजाइनल ब्लीडिंग के साथ भी प्रेजेंट कर सकती है, और इसके एक्सिया पेन ऑन द डेफिकेशन भी हो सकता है। ठीक है, ट्रीटमेंट में हम पेशेंट को काउंसिल करेंगे। अगर पेशेंट पेन के साथ आई है तो एनाल्जेसिक ट्रीटमेंट देंगे, हार्मोनल ट्रीटमेंट देंगे उसको, हल्दी पेन, और इन्वेस्टिगेशन में फर्स्ट लाइन इसकी इन्वेस्टिगेशन से टीवीएस और डीप एंडोमेट्रियोसिस में हम एमआरआई करेंगे, और गोल्ड स्टैंडर्ड है लेप्रोस्कोपी। फर्स्ट हार्मोनल ट्रीटमेंट कौन सा है, ओसीबीज़ हैं, बाकी हम पीओपी भी दे सकते हैं इस पेशेंट को, और जीएनआरएच भी दे सकते हैं। फर्स्ट एनाल्जेसिक क्या है, एनसेड है। ठीक है, और सर्जिकल ट्रीटमेंट एक्सीशंस और एचआरटी हम क्या कौन सी देंगे इस पेशेंट को, कंबाइन देंगे, भले टीएच हुआ हो फिर भी हम पेशेंट को कंबाइन एचआरटी देंगे एंडोमेट्रियोसिस जब होगा तो। अच्छा ठीक है, व्हाट आर दी थ्योरीज रिगार्डिंग द एंडोमेट्रियोसिस। तो अगर एंडोमेट्रियोसिस पैल्विक में हो या पेरिटोनियम में हो तो वो क्यों हो सकता है, इट इज़ ड्यू टू द सिलोमिक मेटाप्लेजिया रिट्रोग्रेडेड मेंस्ट्रुएशन की वजह से हो सकता है। द मोस्ट कॉमन काज ऑफ दी एंडोमेट्रियोसिस अकॉर्डिंग टू दीज थ्योरीज दैट इज द सिलोमिक मेटाप्लेजिया। ठीक है, वो एक एमसीक्यूज आता है, तो एमआरकेएच में अगर एंडोमेट्रियोसिस हो रहा है तो वो किस वजह से हो सकता है, तो वो भी सिलोमिक मेटाप्लेजिया की ही वजह से होता है, क्योंकि यूट्रस तो होता नहीं है पेशेंट में। तो एमआरकेएच पेशेंट जो होते हैं उनमें यूट्रस नहीं होता, तो उनमें जो एंडोमेट्रियोसिस अगर हो भी जाता है तो फिर वो सिलोमिक मेटाप्लेजिया की वजह से होता है। और एब्डोमिनल विसरास और रेक्टोवजाइनल सेप्टम और अम्बलाइकस में भी एंडोमेट्रियोसिस सिलोमिक मेटाप्लेजिया की वजह से हो सकता है। बाकी एब्डोमिनल स्कार है, एपिजियोटमी स्कार है, उनमें डायरेक्ट इम्प्लांटेशन की वजह से हो सकता है। लिम्फ नोड में अगर एंडोमेट्रियोसिस होता है तो वो लिम्फेटिक स्प्लीड, वस्कुलर स्प्लीड, जेनेटिक और इम्यूनोलॉजिकल काजेस की वजह से हो सकता है। ओके, so what are the DDs? Basically the endometrioma is the complex cyst। तो जो कॉम्प्लेक्स सिस्ट की डीडीज़ हैं जैसे कि हेमरेजिक सिस्ट, हम उनको कैसे डिफ्रेंशिएट करेंगे, वो हम अल्ट्रासोनिक फीचर्स में करेंगे। एंडोमेट्रियोमा में हमें ग्राउंड ग्लास अपीयरेंस मिलेगी, हेमरेजिक सिस्ट में हमें शेडिंग साइंस मिलेंगे, और ओवेरियन डर्मोइड सिस्ट उनके भी कुछ अल्ट्रासाउनिक फीचर्स हैं जिन पे हम डायग्नोज करते हैं। ठीक है, और सिस्टिक न्यूप्लाजा में हमें वस्कुलरिटी ज़्यादा मिलेगी, ट्यूब ओवेरियन एब्सिस। दीज आर द डिफरेंशियल डायग्नोसिस ऑफ द एंडोमेट्रियोमा। okay, location, the most common are located in the ovaries, that is the 75%. After that, that is the anterior posterior cul-de-sac, that is 70%, and the 50% in the posterior broad ligament, and the uterosacral ligament it is about 35%, in the uterus 10%, the colon 5%. Okay, so is the endometriosis the clinical diagnosis? No, it is a not a clinical diagnosis. अच्छा, हम सस्पेक्ट कब करेंगे, अगर पेशेंट यंग है और उसकी एज 17 या 17 से कम है, और हम सस्पेक्ट कर रहे हैं एंडोमेट्रियोसिस अगर इनमें से कोई भी एक फीचर्स इसमें हो या एक से ज़्यादा हो साइन और सिम्टम्स। ठीक है, या तो उसको डिस्मेन्यूरिया हो पेशेंट को, या जीआई सिम्टम्स हो, या ब्लैडर और बाउल सिम्टम्स हो, या इनफर्टिलिटी हो। ठीक है, इनमें से कोई भी एक हो या एक से ज़्यादा हो तो हम सस्पेक्ट कर सकते हैं पेशेंट को एंडोमेट्रियोसिस से। ठीक है, तो उसके बाद हमने पहले हिस्ट्री ली। ठीक है, हिस्ट्री में पेशेंट ने हमें एक या दो सिम्टम्स बता दिए। उसके बाद हम क्या करेंगे, एब्डोमिनल एग्जामिनेशन करेंगे और पेल्विक एग्जामिनेशन करेंगे। ठीक है, हम क्या देखेंगे, टू रूल आउट एनी एब्डोमिनल मास, टू चेक दी टेंडरनेस इन द एनलार्जमेंट ऑफ दी uterus, and we will check the nodularity in the posterior vaginal fornix and the visible vaginal endometriotic lesion. So these are the examination points that we are seeing during the examination. Okay, so when the patient come in the community or in primary care, so what treatment they can give in. कम्युनिटी में अगर पेशेंट आएगा हमारे पास तो फिर हम वहाँ पे नॉन हार्मोनल या हार्मोनल ट्रीटमेंट भी दे सकते हैं, ठीक है। अगर उनसे अगर ट्रीट ना हुआ, बार बार पेशेंट को रिकरेंट है या परसिस्टेंट एंडोमेट्रियोसिस है या सीवियर है, तो वो फिर रेफ़र करेंगे गायनेकोलॉजिस्ट के पास, ठीक है। ठीक, फिर गायनेकोलॉजिस्ट कौन से पेशेंट को ट्रीट करती है? जब एंडोमेट्रियोसिस सीवियर हो, परसिस्टेंट हो या रिकरेंट हो, या पेल्विक साइंस ऑफ द एंडोमेट्रियोमा प्रेजेंट हो, ठीक है। या उसको जो हार्मोनल या नॉन हार्मोनल ट्रीटमेंट पे पेशेंट ट्रीट ना हुई हो, तो फिर हम रेफ़र करेंगे उसको गायनेकोलॉजिकल ट्रीटमेंट गायनेकोलॉजिस्ट के पास, ठीक है। अच्छा, अगर endometriosis is the deep, ठीक है, that involving the bladder, bowel and the ureter, then we will refer it to the specialist endometriosis service, and we will refer the patient if it is age is 17 and under the 17. So in these cases we will refer it to the स्पेशलिस्ट एंडोमेट्रियोसिस सर्विस, ठीक है। तो फिर ये आपको आना चाहिए कौन से केसेस हम स्पेशलिस्ट एंडोमेट्रियोसिस सर्विस के पास रेफ़र करेंगे और कौन से केसेस हम गायनेकोलॉजिकल सर्विस के पास रेफ़र करेंगे, ठीक है। ओके। अच्छा, इन्वेस्टिगेशन सबसे पहले जो फर्स्ट लाइन इन्वेस्टिगेशन, जब हमारे पास पेशेंट साइन और सिम्टम के साथ आती है, हमने एग्जामिनेशन की, ठीक है, तो फिर हम टीवीएस करेंगे, ठीक है। अगर पेशेंट टीवीएस नहीं करवाना चाह रही तो फिर उस केस में हम टीएएस भी कर सकते हैं। अगर पेशेंट को डीप एंडोमेट्रियोसिस की साइन और सिम्टम्स हैं तो फिर हम एमआरआई करवाएंगे, और गोल्ड स्टैंडर्ड जो उसकी इन्वेस्टिगेशन है वो है लेप्रोस्कोपी। एमआरआई के बाद भी अगर डीप एंडोमेट्रियोसिस डायग्नोस हो भी गया तो फिर उसके बाद भी हम लेप्रोस्कोपी ज़रूर करेंगे, ठीक है, टू फर्दर कन्फर्म आवर डायग्नोसिस। अच्छा, there is a no role of the CA125 even if the CA125 is a normal, but still the patient have the endometriosis, so there is a no value of the CA25 to diagnose the endometriosis. MRI we already discussed, we will do the MRI in the case of the deep endometriosis, but after the MRI we will further confirm our diagnosis by the laparoscopy. What is the criteria for the diagnostic laparoscopy? Okay, so we will do the laparoscopy to further confirm our diagnosis. Even there is a no finding in the TVS, but still we will do the laparoscopy to confirm the diagnosis of the patient present with the sign and symptoms of the endometriosis. During the laparoscopy, we will must do the biopsy of the endometrial tissue to exclude the endometrial carcinoma. Okay. If the after the laparoscopy, if there is no diagnosis of the endometriosis is found, so we will counsel the patient that she does not have the endometriosis, and we will give the alternative options of the management. Okay, we will keep the patient on follow-up if the patient have the deep endometriosis of the, or if the patient have the endometrioma that is the large and the 3 centimeter in size. In these patient we will consider the outpatient follow-up. Okay, so if the patient present with the endometriosis and having the complaining of the pain, so what are the pharmacological treatment options? We will give the treatment at least for the 3 months, and we will give the NSAID or the paracetamols. We will give the alone or in the combination form. If she is not treated, then we will refer for the hormonal treatment. So what are the hormonal treatment? That is the OCPs, POP, GnRH. Okay. If it is if these initial treatment is failed, then we will do the surgical treatment, that is the laparoscopically excisions, ablations of the endometriotic tissues. After that we will give the hormonal treatment to decrease the further recurrence of the endometriosis. We will do the hysterectomy at the end. If the all treatment is a failed, then we will do the hysterectomy, and we will exercise the all visible endometriotic lesion at the time of the hysterectomy. Perform the hysterectomy with or without the oophorectomy laparoscopically when the combined with the surgical treatment of the endometriosis, unless there are contraindication. Okay. सो जब हमारे पास पेशेंट एंडोमेट्रियोसिस के साथ आती है, उसकी मेन कंप्लेंट पेन है, तो उसकी हमने मैनेजमेंट पढ़ ली है कि हम उसको फार्माकोलॉजिकल ट्रीटमेंट देंगे। उसमें इनिशियल हम क्या ट्रीटमेंट देंगे, एनसेड या पैरासीटामोल दे सकते हैं, और हार्मोनल में ओसीपीज, पीओपी और GnRH दे सकते हैं। अगर इनसे ट्रीट ना हुई तो हम पेशेंट्स को लेप्रोस्कोपिकली एक्सीशन, एब्लेशन, सिस्टेक्टमी इसके लिए काउंसिल करेंगे, ठीक है। एट दी एंड हम सिस्टेक्टमी करेंगे। अच्छा, इनफर्टिलिटी के लिए एंडोमेट्रियोसिस में ट्रीटमेंट अलग है, पेन के लिए ट्रीटमेंट अलग है। तो हम पेशेंट से पूछेंगे अगर आप क्या चाह रही हैं। इनफर्टिलिटी के लिए पेशेंट आई है तो फिर उस हिसाब से हम ट्रीट करेंगे उसको, अगर पेन के साथ आ रही है तो फिर उस हिसाब से करेंगे। सो व्हाट आर द ट्रीटमेंट ऑप्शंस इन द इनफर्टिलिटी? Offer the excisions are the ablations of the endometriosis plus the radiolysis for the endometriosis involving the not involving the bowel bladder, ठीक है। अगर पेशेंट को माइल्ड या मिनिमल एंडोमेट्रियोसिस है, ठीक है, सुपरफिशियल है, that are not involving the bowel bladder or the ureter, so in these cases we offer the excisions or the ablation that increase the fertility rate. Okay, we offer the cyst drainage and the cystectomy along with the excisions of the cyst wall that also increase the spontaneous pregnancy rate and reduce the recurrence rate. Okay, before the treatment we will discuss the benefit and the complications of the treatment to the patient. Okay, we will don't offer the hormonal treatment to the women with the endometriosis trying to conceive, ठीक है। अच्छा, पहले जैसे हम पेन की जब मैनेजमेंट कर रहे थे उसमें हम पोस्ट ऑपरेटिवली पेशेंट को OCPs या हार्मोनल ट्रीटमेंट दे रहे थे ताकि उसको रिकरेंस ना हो, उसके सिम्टम्स जो हैं वो इम्प्रूव हो जाएं। बट अगर हम इनफर्टिलिटी के लिए ट्रीटमेंट करेंगे तो फिर हम उसमें हार्मोनल ट्रीटमेंट नहीं देंगे। देन वी विल रेफर द पेशेंट आफ्टर द सर्जरी, वी विल रेफर टू द ART सेंटर, बिकॉज वो कंसीव करना चाह रही है तो फिर हम उसको ART सेंटर में रेफर करेंगे। अगर हम उसको हार्मोनल ट्रीटमेंट देंगे दैट आर दी कंट्रासेप्टिव and patient want to the want for the treatment of the fertility, then we will does not give the these treatment. We will refer to the ART center that further guide her for the assisted reproductive conception. ओके, इनफर्टिलिटी के लिए हम कौन से ट्रीटमेंट करेंगे? ऑपरेटिव जो लेप्रोस्कोपिकली एक्सीज द लीशंस, एब्लेड नेम, एडोलाइसिस, प्रीफर द लेज़र वेपराइजेशंस ओवर द रूटीन डायथर्मी। ओके, अगर ये है जब स्टेज 1 या 2 हो, ठीक है, माइल्ड या मॉडरेट में। अगर स्टेज 2 या 3 और 4 हैं, जब डीप एंडोमेट्रियोसिस हो, तो उसमें हम IVF ही करेंगे, ठीक है। उसमें हम सर्जिकल ट्रीटमेंट की तरफ नहीं जाएंगे। एंडोमेट्रियोसिस साइजेस मोर देन 4 सेंटीमीटर, ठीक है। हम सर्जिकल ट्रीटमेंट उस केस में करेंगे 3 और 4 में जब हमें एग रिट्राइवल में प्रॉब्लम हो, ठीक है। व्हेन देयर इज अ डिफिकल्टी टू द एग रिट्राइवल, देन वी विल डू द सर्जरी of the endometrioma that is more than the 4 centimeter size. But if the endometrioma is 6 centimeter size and there is a no difficulty to the egg retrieval, then we will does not go for the surgical option, we will go for the directly go for the IVF. Okay, endometriosis infertility management, stage 1 or stage 2, that is the mild and the minimal, we will do the conservative surgery that we already discussed, that is the excisions, ablation and the radiolysis that improve the pregnancy outcome. And if the no pregnancy till the 2 year, then we will go for the IVF. Another option, we will give the expected management, we does not do the surgery and we will keep the patient on the expected management for the 2 year. If it is a still not conceived, then we will go for the IVF or the medical assisted reproductive technique. Okay, in the case of the stage 3 and the 4, we will directly go for the IVF without the surgical treatment if there is no difficulty to egg retrieval. Okay, in stage 1 and the 2, excision and the ablations in the endometrioma, cystectomy with the cyst wall removal aim to enhance the spontaneous conception. Use the EFI scores for the non-IVF pregnancy to decide about the surgery. Okay, in stage 3 and the 4, excision and ablation and the endometrioma, cystectomy with the cyst removal is aim to enhance the egg retrieval. Okay, वो हम सिर्फ तब करेंगे जब हमें एग निकालने में मुश्किल हो रही हो, तो उस केस में हम करेंगे, अदरवाइज वी विल नॉट डू द सर्जरी इन दी स्टेज 3 and the 4. Bigger endometrioma, that is the 5 centimeter in size, do the 3-stage removal. We will discuss it later that what is the 3-stage removal. Laparoscopic ablation and the drainage of the endometrioma, more ovarian reservoir preservation versus to the cystectomy. Okay, we already discussed it that these are the options for the pain management in the patient having the endometriosis. The first line is the NSAID and the paracetamol, and in hormonal, that is the OCPs and the progesterone. Second line is the GnRH, third line is the aromatase inhibitors, and fourth is the denazole when iron treatment are the fail, and the fourth is the surgery, that is the conservative and the radical surgery. Okay, so this is the summary of the surgery recommendations for the surgical intervention before the assisted reproductive technique. If the patient have the hydrosalpinx, then we will do the salpingectomy. Then after that we will do the IVF. In the uterine septums, we will do the hysteroscopic septoplasty. In the intramural fibroid and the submucosal fibroid, we will do the myomectomy. And in the polyp, we will do the polypectomy. And the superficial endometrioma, we will do the laparoscopically treatment. And the deep endometrioma surgery for the symptoms relief only. Surgery done if the size of the endometrioma is more than the 5 centimeter in the size and there is a difficulty to the egg retrieval. In these cases, we will do the surgery. Okay. Already we discussed these sign and symptoms. We discuss it. The treatment options for the pain, we already discussed these reference from the eshure guideline. Role of the insert in the endometriosis. Overall, the limited risk and the considering the wide availability and the use of the analgesic, concluded that the NSAID and the other analgesic may be offered for the treatment of the endometriosis associated pain. That is the weak recommendation. We already discussed about that the hormonal treatment that are used in the endometriosis. The first line treatment is the OCPs and the progesterone. Second line is the GnRH agonist and GnRH antagonist, that also for second line treatment, and third line is the aromatase inhibitor. Okay, so what is the use of the GnRH in the endometriosis? It is recommended to prescribe the woman GnRH agonist to reduce the endometriosis associated pain, although the evidence is limited regarding the dosage and the duration of the treatment. The GTG is recommended that the GnRH agonist are prescribed as a second line, for example, if the hormonal contraceptive or the progesterone have been ineffective and due to their side effect profile. If the GnRH is used more than the 6 months, then we will give the add-back therapy because it causes the menopausal symptoms due to the loss of the estrogen activity, and when there is the hypoestrogenic symptoms is present, we will give the add-back therapy. What is the add-back therapy? That is the estrogen or progesterone monotherapy, that is the northestrone, and estrogen and the progesterone in combination, and the selective estrogen receptor modulator, and the bisphosphonate and tabolone and the testosterone. All the symptoms that are present in the menopause. So we will give the add-back therapy in this patient when she is taking the GnRH and that she is taking more than the 6 months. Okay, so what is the efficacy of the GnRH agonist? GnRH agonist is more effective than the placebo but inferior to the LNG intrauterine device and oral denazole. There is a no contraindication to use of the denazole. We can give the denazole in the patient if the all treatment option is failed, and but we will tell the patient that she has the side effect just like the acne, edema, vaginal spotting, and weight gain, muscle cramps, deepening of the voice, and increasing of the facial hair. So when the all treatment option is a fail, then we will give the denazole in the patient, but after the telling her the side effect and the complications that are present in the denazole. Okay, so we already discussed it. Okay, so in the recent talk article, it is clearly mentioned that there is a weak recommendation about the IUI in the mild and the minimal endometriosis. We will offer the IVF in these cases, and in stage 3 and the 4, we directly offer the IVF to the patient, and we will do the surgery only when there is a difficulty to the egg retrieval. The GTG recommended that the clinician inform women with the endometriosis requesting the information on the risk of the developing the cancer. There is a no evidence that the endometriosis causing the cancer. There is a no increase overall incidence of the cancer in the woman with the endometriosis, but some cancer mildly increase in the patient having endometriosis. What are those cancer? That is the ovarian, thyroid, breast, and the non-Hodgkin lymphoma. Among them, there is increased risk of the clear cell carcinoma of the ovaries and the endometrioid cancer. That is slightly increase in the cases of the patient having the endometriosis. So we already discussed about that is the endometriosis is the chronic inflammatory condition that result in the systemic and the local inflammatory changes, and there is increased cytokine and the chemokine involved in the inflammations in the numerous immune cell type, macrophage, T cell, and the B cell natural killer cells are dysregulated, result in a decrease in endometrium reception. Okay, we already discussed about the laparoscopy and the MRI. In which cases we will do the laparoscopy, and what are the cases in which we will offer the MRI. Already discussed. And mm, okay, so the pregnancy rate after the excisions of the deep endometrioma with the or without the bowel involvement is about the 20 to 30%. Okay, cystectomy and the ablation had the pregnancy rate approximately 30% versus the simple drainage. Eshure recommended the surgeries undertaken cystectomy should be performed to reduce the risk of the recurrence. Okay, so we will discuss about that what is the three-stage excision. We will do the three-stage excision in the cases when the endometrioma is more than the 5 centimeter in size. So in the first stage, we will do the laparoscopic cystic drainage followed by the GnRH agonist down regulation, and then we will repeat the laparoscopy to excise the cyst capsule. So it is done in the three stage, and it is done only in the patient only those patient having the cyst is more than the 5 centimeter in size. Okay, in this slide we will discuss that is the what is the advantage and the disadvantage of the cystectomy, ablation, and the drainage. Advantage of the cystectomy that it has the less recurrence rate and less ovarian function loss. Okay, so in the endometrioma, what is the advantages of the cystectomy, ablation, and the drainage? Advantage of the cystectomy is that it has the less recurrence, and in ablation and the drainage there is the less ovarian function loss. Disadvantage of the cystectomy is that there is a more ovarian function is loss, and in ablation and the drainage there is a more recurrence. Technique that is used in the cystectomy is the one stage excisions or the three stage excision. We already discussed about the three stage excision, and the one stage excision is done when it is a less than the 5 centimeter in size, but if it is a more than 5 centimeter in size then we will do the three stage excision. First of all we will do the laparoscopic drainage, then we will give the GnRH, and then we do the again laparoscopy to excise the cyst. Okay, in the both cases the pregnancy rate is the 30%. What is the technique of the ablation and the drainage? That it is to avoid just simple drainage and add ablation too. We already discussed about the treatment option in the minimal, mild, moderate, severe, and endometrioma. In minimal and mild, we will do the expected management, and we will do the conservative surgery and keep the patient for up to the 2 year for the natural conception. If there is a no improvement, then we will go for the IVF. In moderate and severe, we will directly go toward the IVF, but we will do the surgery in only case if there is the difficulty to the A grade survival. Endometriosis affected 10% of the reproductive age women. preform superficial endometrioma, and the deep infiltrating. What are the ultrasound criteria? There is a unilocular or the multilocular cyst and homogeneous low level of the echos is present. Endometrial gland present on the cystic wall and the hemosiderin-laden macrophage is also present. Ovarian function, the lower ovulation in affected ovaries and ovarian reservoir reduce after the post cystectomy. Okay, we will discuss about the conservative management, medical and the all surgical option. Okay, so assisted reproductive technique. When we will do the assisted reproductive technique in the patient having the age is more than the 35-year-old, and when there is a bilateral endometriomas and there is a low ovarian reservoir, and male factors are the dual factor infertility. Surgery is indicated for the pain relief and when there is a larger the suspicious cyst and in the ovarian torsions and the patient declining the ART. Okay, what is the EFI score and what is the NCN scoring system and AFS scoring system? Now we will use the EFI score. We will use the EFI score to predict the pregnancy rate in the woman with the surgically assessment of endometriosis, attempting the known IVF conception for shared decision making. So we will use this score only to predict the pregnancy rate in those patients who want the surgical treatment to conceive. An EFI score depend on the symptoms, age, history of the previous surgery, the presence of the other fertility factor, and the ovarian reservoir. It is equal to the total historical factors plus total surgical factor. Okay, first, in previously we will use the ancients scoring system. We will use for the preoperative predictions of the laparoscopically operative time, and there is a little correlation of this score system with the patient symptoms and the infertility. AFS scoring system, it is also used in previously, but now we will use the EFI system. AFS is used to classify the extent of the disease and its relationship with the pregnancy rate, and it does not correlate with the pain and the subfertility. Surgical treatment for the ovarian endometriosis. Okay, we will already discuss it. This is the recent talk article that was updated in 2024. Ovarian endometrioma referred primarily to the endometriomas that are the blood-filled cyst lined by the endometrial-like tissues. Surgical technique to elevate the pain, improve fertility, and reduce the recurrence. What are the indication of this surgery? When the patient has a severe and the persistent pain that do not respond to the medical treatment, and when the endometrium is more than the 4 centimeter in size and patient want to the fertility, and when there is a diagnostic uncertainty and associated infertility in such cases. In all these cases we will do the surgery. Okay, so MH testing maybe guide the fertility discussion. We will do the MH and our entire enteral follicle count before the surgery if the patient want to fertility. What are the goal of the surgery? That is a complete excisions of the endometrioma capsule while preserve the ovarian tissue. Okay, we discuss about the cystectomy and the ablation. We can do the in combination. We will do the cystectomy as well as the ablation. So if we will do simultaneously both of these techniques, then we will call as the combination technique, in which we will do the partial excisions of the cyst wall combined with the ablations of the residual part near the hilum. Why will do it? We will do to balance the recurrence prevention with the ovarian preservation, and emerging evidence show the favorable result in the specific fertility preserving setting. Okay, we will use the bipolar cautery associated with the greatest reduction in the ovarian reservoir. So we will not use the bipolar cautery in these cases because it reduces the ovarian reservoir. Okay, what are the recurrence rate after the post-operative treatment? Recurrence rate is the 20 to 40% within the 5 year. Hormonal suppression is given after the post-surgery if the patient having the complaining of the pain and she does not want to fertile conserve fertility. So we will do the pain treatment after the surgery. That is the OCPs and the progesterone. ART often follow the surgery in the subfertility women. Okay, we already discussed. We will refer to the ART in those patients who have the surgery for the infertility purpose. In those patients, we will does not give the hormonal treatment. We will refer to the ART center. Generous agonist can be given the pre and the post-op can improve the outcome in the selected cases, but there is a small evidence suggests that we will give the generous agonist because it has the menopausal symptoms. So if we will give, then we will give the APEC therapy. Long-term follow-up and the monitoring, we will do the AMI monitoring in the patient, the fertility planning, and we will do the surgery of the patient. Then we will keep the follow-up, and in the follow-up we will do the AMH. Bilateral endometriomas carries the high risk of the iatrogenic, premature and ovarian insufficiency. Though surgery should ideally be performed in the specialist endometriosis center, and there must be the involvement of the MDT team. Okay, so these are the key points. Cystectomy is the gold standard for the pain and the fertility outcome. Ablation has the higher rate of the recurrence and the least ovarian damage. Combination technique may optimize the balance of the efficacy and the ovarian reservoir. Laser in the plasma energy is preferred over the bipolar to preserve the ovarian function. Consent should take in, including the discussion on the reduced ovarian reservoir. Avoid the repeat surgery if possible. Consider the ART instead. Post-operative hormonal suppression can reduce the recurrence, but it is only given in the patient who does not want to conserve her fertility or who does not want to conceive. Okay, so conservative management should certainly to be the first line options for the endometriomas, especially that is the less than the 3 centimeter in the size, while the medical management can reduce the size of the endometrioma up to 57%. ठीक है, तो कंजर्वेटिव मैनेजमेंट हम कब करेंगे? जब एंडोमेट्रियोमा की साइज़ 3 सेंटीमीटर से कम हो, और मेडिकल ट्रीटमेंट से एंडोमेट्रियोमास की साइज़ कितनी रिड्यूस हो सकती है? 57%. Okay. So endometriomas increase the risk of the certain cancer. We will discuss that it increase the risk of the clear cell carcinoma and the endometrioid cancers, and the some thyroid small increased risk of the thyroid and the breast cancer and the ovarian cancer. Okay, the absolute risk of the malignancy remain low. Endometrioid often rises from the endometriomas or the atypical endometriosis. Routine ovarian cancer screening is not recommended for the patient having the endometriomas. OCPs may use to reduce the risk of the endometrial ovarian cancer. Surgical excisions of the endometriosis lesion reduce the future pregnancy, future malignancy risk. Okay, these are the mutations that are found in the endometrioid cancer. Clear cell carcinoma show the poor response to the chemotherapy and the worsen prognosis. No validated screening tool exists for the early ovarian cancer is in the endometriosis. The management aligns with the epithelial ovarian cancer. Okay, so that's all about the endometriosis.